I haven't treated anybody in my life, but my problem with that is it does not seem like there's much evidence at all of the superior efficacy of 2 antipsychotics, never mind 3 or 4 antipsychotics for a patient. This is just some excerpts from some of the recent literature. So there was a review by Gorin on the top there where he says there's basically zero support in randomized clinical trials, at least for the use of 2 antipsychotics for non-treatment resistant patients. For treatment resistant patients, there's a little bit of evidence, but 99% of it is associated with augmenting clozapine, which is rarely used in Medicaid, rarely used much of anywhere. There was an article published, written by Carell in 2009, where he makes a little more of an argument that there is some support for antipsychotic polypharmacy, but when you look at what he bases his conclusions on, almost all the studies are from China. They're almost all involve clozapine, and they tend to be having used antipsychotic polypharmacy in ways that they're rarely used here, like starting patients on 2 antipsychotics as opposed to augmenting them. So the evidence seems really scanty. And then this last piece was just published a few months ago, Susan Essig, which is a new randomized controlled trial that some of you may have seen. It came out of, I guess, a follow-up to from the Katie data anyway. So they took, I think it was 125 patients who came into the clinic on 2 antipsychotics, unhappy with their symptoms. And those patients with schizophrenia were randomly assigned to either stay on the 2 that they were on or to switch to one of the 2. And then they were followed for 6 months, measured using PANSS and some of the standard scores. And what they found was the patients that went to antipsychotic monotherapy discontinued their medication. In other words, they switched to something else faster than the others. But 6 months later, and if you look at the data for every month along the way, symptoms were no worse for the patients that were on 1 versus 2. So they conclude that patients that are on 2 should at least be given a trial or offered a trial of monotherapy to see if they would do okay. So anyway, a lot of this practice going on, a lot of belief that it's a reasonable, in fact, efficacious thing to do. Very little support for it, even in terms of the theoretical underpinnings of why you would do this. It doesn't seem like there's any support, given the mechanisms of action seem to be pretty much the same with these medications. But the problem is, in terms of convincing physicians, the data aren't that fulfilling because most of it is isolated to a relatively small number of agents. Most of the studies are relatively short term, and the results are a little mixed. So anyway, that's the background for why we decided to initiate out of this program a clinical trial called The Risks and Benefits of Switching Patients with Schizophrenia from 2-to-1 antipsychotic medication. So this is part of the program that's funded by Medicaid. This is the inclusion criteria. You'll see in a minute, we pretty much mirrored the Essig study. It seemed like the Katie group, there was somebody to imitate. It was probably a reasonable group to imitate. But there are a couple of differences that may turn out to be important. One is this no independent plans to change antipsychotic regimen in the next 30 days. So the idea is somebody's on antipsychotic polypharmacy and the patient isn't necessarily complaining about it and the physician isn't saying, gee, I need to change this. The other thing is the sites, and we have, the sites are 3 community mental health centers, and physicians associated with those mental health centers are here tonight. There's one over there, Dr. Mobley. Oh, yeah, hiding there. Jim Zanell at Directions, and Dr. Dorta Duque from Peace River. So the other, I think, difference we're going to see is that in the Katie study, the average PANSS score for the patients in the study was 69, I think. just a little bit below moderately ill. Two of the three sites in this study are going to be drawing patients from assertive community treatment teams. So I'm expecting the PAN scores are going to be much higher, and we'll get a chance to look at a much more severely ill, disabled population, I think, than the Essex study did. And then the last thing is we're going to follow them using basically the same measure for 12 months instead of 6. So these are the exclusion criteria. They're in your handout, so I won't read through them. So this is an attempt to try to picture the design here. So we've got 50 patients in each of these community mental health centers that meet the inclusion criteria and are not excluded by the exclusion, randomly assigned within each of the sites to switch to monotherapy or to stay on the two they're on, or to switch to one of the two. We have baseline measurements, and the next slide shows what the measurements are. And then we're going to take measurements on these patients at 60, 120, 180, 240, 300, and 360. Obviously, the physician is not going to be blinded to the medication, nor will the patient. The only blinding in this study will be the person doing the assessment. These 60, 120, 180 days, the assessor will not know whether the patient is in the switch condition or the stay condition. So these are the outcome measures. They're fairly standard group of symptoms and functioning and side effect scales. The Duke Health Profile we added. We are going to use Medicaid pharmacy claims to, after the fact, we get those claims at USF, but we get them about a quarter later. So we're going to use the claims to try to confirm the adherence of the patient to the medication. So they'll tell us what their adherence is through the MAQ, but we'll have some data from the pharmacy claims that could confirm that. If the data don't confirm that, it's still possible they got the medications elsewhere, but at least it's something that we can ask the patient to try to get some sense of whether they're actually taking the meds. So we'll do BMI and blood pressure every 2 months, and then the A1Cs and fasting lipids we'll do at baseline 6 months and 12 months. This is the current status. At long last, the IRB at USF is approved. The 2 of the 3 sites used the Western IRB. That was so much easier. But they had our IRB to work with, so that probably made it easier. Research staff are hired. The database has been created and deployed to these 3 sites. We've done the random assignment of patients as they're enrolled. Screening of patients is underway. I think Directions has found 7 or 8 patients already that are ready to be enrolled. So enrollment begins hopefully next week rather than the next couple of weeks. The 3rd site we're running 2 or 3 weeks behind, but we're about to schedule the training of the independent assessors. And so probably a couple weeks from now we'll start enrolling at the 3rd site. So that's the study. We hope to enroll over 4 to 5 months. We hope to get about 150 patients, and then we'll follow them each for 12 months. So it'll take us 18 months to finish this study. So the agenda for tomorrow, we have Dr. Tandon starting off with schizophrenia, and Terry Ketter, bipolar disorder. Then we have John Newcomer doing the effects of antipsychotic, the side effects of antipsychotic medications, not just metabolic, but we have a review and revision of the antipsychotic UPMI. Remember those indicators that we're looking for. So we might change, you might want to change some of those or add some related specifically to the use of antipsychotics. And then Sunday, we're going to do major depression disorder first thing with Dr. Sen. Is Dr. Sen here? Ah, hi. Sorry, I didn't meet you before. Again, we're hoping there might be some recommendations for UPMI associated with antidepressants. We'll finish Sunday morning with a panel discussion about strategies for enhancing the appropriate use of clozapine. Our guidelines and just about every other guideline for schizophrenia that I'm familiar with recommends the use of clozapine for treatment-resistant patients. Yet even in assertive community treatment teams, the percentage that are treated with clozapine is relatively small. And there are reasons for that we know, but there may be some strategies that can facilitate use, and we're at least prepared to consider those strategies for implementation in the program if they make sense. And then we'll adjourn around noon, I think, right, Murray? Okay. So that's the agenda of the process. The expert will do the presentation of evidence related to the medication treatment of the disorder they're assigned to over pretty much the last 2 years. So we're updating the guidelines that were updated 2 years ago. Those have historically, and I hope will continue to be, informal kinds of presentations that allow for at least, asking questions and clarifications and that sort of thing. At the end of their presentation, the experts will make specific recommendations about what changes they think the evidence suggests be made in the guidelines as they exist now. The group will discuss each of those recommendations in turn and decide whether they want to accept them or modify them. And then if it's not clear that there's an absolute consensus, we'll actually do a vote on it. And that's the end.